All right, good afternoon, everyone. As you're jumping on, just to let you know, my name is Mia Pappas, and I'm the Chief Scientific Officer at the ChristianaCare Institute for Research on Equity and Community Health, as well as the ChristianaCare Site PI for the ACCEL Delaware CTR program, the program that brings you these Tech Talks and Innovative Discovery Series seminars. A few announcements before we get started. First, if you're in need of CME information for today's talk, please reach out directly to Deborah Reese, who will have her email address in the chat box, and she can walk you through the process of obtaining CME. And next, mark your calendars for Thursday, February 16th at noon for our next Tech Talk, where Dr. E.L. Oren from San Diego State University will be discussing the tobacco endgame. What would it take for a complete ban on smoking? Hopefully the tobacco endgame is not as fictional as the Avengers endgame. So welcome today. I am delighted to introduce our speaker today, Jessica Webster. Jessica holds a Master of Public Health degree in epidemiology from the Eakin School of Medicine at Mount Sinai in New York. Never know how to say that. She is currently a third-year doctoral candidate in epidemiology at Drexel University's Dornsife School of Public Health, where she is investigating transmission dynamics and risk factors for healthcare-associated C. diff infection. The unifying theme of her research is focused on using advanced methodologies to better understand complex relationships between both infectious and non-infectious exposures and health outcomes. She has worked as a research assistant all over the world, from Paris, France to Jinja, Uganda. And directly prior to her entering her PhD program at Drexel, she worked in immigrant and refugee health at the CDC and in epidemiology services at the New York City Department of Health and Mental Hygiene. We are delighted that she is here with us this afternoon, where she will be speaking with us on the topic of ArcGIS location-allocation analysis as a tool for evaluating disparities in mammography screening facilities. Welcome, Jessica.
Thank you so much for the introduction. So I'll just get right into my presentation, and as you heard, it's on ArcGIS location allocation analysis as a tool for evaluating disparities in mammography screening facilities. So I'll start with a brief background on using GIS in healthcare and discuss the importance of evaluating access to care. I'll introduce ArcGIS Pro's software and the Network Analyst extension. I'll give a high-level overview on the study that we're currently conducting and using these analyses on, and then I'll go over how we prepared our data for the analysis. I'll then demonstrate the two analyses we conducted, the service area analysis and the location allocation analysis. And then I will end with a quick note on how these tools could be used in practice, any limitations, and then open it up for questions. So why is it important to use GIS in healthcare research and program or policy planning? A few notable methodological challenges when evaluating geographic health data include heterogeneity across geographic areas, urbanicity, as well as irregularity in population distribution. In the US, there is a huge heterogeneity in culture, politics, policy, and health programs across geographic spaces. And this, in turn, can lead to heterogeneity in health exposures as well as outcomes. And just as an example, in 2010, Mobley and colleagues evaluated disparities in cancer screening behaviors between racial and ethnic groups within several US states. And they found that while the majority of states were consistent with the national benchmark, which estimated that Black and Latino, Latinx adults were less likely to use cancer screening services, in certain states such as Michigan and New Jersey, these groups were actually more likely to use these screening services compared to white adults. And the authors explain that this could be in part due to efforts made in these specific states to increase awareness of certain cancers and the importance of screening. Another important reason for using GIS in healthcare research is the variations in levels of urbanicity and its potential impact on health outcomes. And to illustrate that, Wang and colleagues demonstrated in a study from 2009 where they looked at the risk of 4 major types of cancer in the Chicago area. They created 5 categories of urban zip areas within and around Chicago, and they found that risk for all types of cancers studied was highest in the most urbanized areas, and then decreased as urbanicity declined, but then had a slight uptick in the most rural, isolated areas. And then finally, the irregularity in geographic population has led to unequal workload in certain areas for healthcare providers and staff, as well as what we have focused our research on today, which is the disparities in accessibility to health services. So as I'm sure you all know, access to healthcare is complex and multifaceted. And in this presentation, I would like to highlight the accessibility facet, which focuses specifically on geographic convenience to health services. And related specifically to accessibility, there are various physical barriers in access, such as distance from a healthcare facility, road access, as well as modes of transportation. And one way that we can think of accessibility to health services is by considering patients as being the demand and health services as being the supply. And as you'll see in the next few slides, health researchers have kind of borrowed these concepts and methods from other fields to help map and analyze accessibility to healthcare services using network analyst tools. So ArcGIS, if you are not familiar with it yet, is a geographic information systems or GIS desktop application, although they do also have an online version, but with fewer features. ArcGIS and ArcGIS Pro allow for spatial data visualization and analysis. The ArcGIS Pro Network Analyst extension is an added feature that you can include in your ArcGIS Pro software that allows you to use and measure distances and travel times along a network. You can create drive time buffers or use service areas. And you can also find the best locations for facilities to serve demand. And in our project, we focused on these last 2 features specifically, creating service areas and finding locations for facilities. Service area analysis uses network analytics to identify areas that are accessible around a specific location on a network. And typically when we're using GIS software, this network is usually a road network. And this is based on how long it takes to drive or walk to or from a specific location. So within ArcGIS, you can specify the locations of the facilities that are providing the services. And you can also specify the number and characteristics of the service area breaks that you're interested in measuring, which could be in driving time or driving distance, or if you're using walking, walking time and walking distance. You can also specify the direction of the movement. So for example, if we are thinking about the locations as being clinics, how long would it take the patients to drive to the clinics? Or alternatively, if we are thinking of the locations as being EMS stations, we may want to know how long it would take an ambulance to get to the person requiring emergency medical services. And then additionally, not a requirement, but you can also specify the time of day and whether you want any overlap in the service areas of nearby locations. And this service area tool is useful because it helps to evaluate and visualize accessibility, which, for example, you can see in this map on the slide. So in this example image, you can see that they have selected 5 different cities as the locations, and there are 3 service areas surrounding each location. And so just by estimating, I'm assuming the green, the closest area, is about an hour driving time from the location. The yellow would probably be about 3 hours driving time. And then the red is likely about 5 hours driving time away from the cities. So the second tool that we'll be discussing is the location allocation analysis tools. And these can be used to identify locations for facilities that provide a certain service. So this could be a healthcare facility or even a convenience store. And the ideal location of this facility is determined based on the demand for its services in a local area. So as I mentioned previously, demand is the number and location of individuals requiring the service that the facility provides. These models determine the most efficient locations based on where the demand points are located and a set of criteria or constraints such as travel time, capacity, or distance to the facility. And in addition to these criteria or constraints, weights can also be applied to the demand points to determine the extent to which individuals within a specific group or subgroup of the population are in need of these services. So this example here on the slide shows a location allocation analysis that determined the best locations for 2 grocery stores based on which ones capture the most demand or are accessible to the greatest amount of people. So in this example, all of these little triangles are demand points, and you can see which location all of the demand points would be allocated to. So now I'd like to begin the demonstration of these tools using an example of a recent project that I've been working on that uses catchment and location allocation analysis to estimate mammography access in Delaware. And the motivation for this work was that despite an overall reduction in breast cancer mortality in the last 40 years, disparities based on race, socioeconomic status, and rurality continue to exist in the U.S. and are often linked to later stage of diagnosis. So ensuring equitable access to screening mammography is an important priority for reducing breast cancer disparities. So with this in mind, we aimed to characterize the variation in mammography access using the ArcGIS service area analysis tool. We then aimed to identify any candidate locations for placement of additional mammography facilities based on different demand specifications using the ArcGIS location-allocation tool. So all of the data that we used in this analysis were publicly available. And with any GIS project, the first thing you'll need to do is get a shapefile for the location that you're interested in mapping. So the census.gov website has shapefiles available for download on the state level and even within states on the zip code level or census tract level, and many more options. So we downloaded data on the census tract level for Delaware. We also downloaded data on the population centers within the states, which I'll explain a little bit in more detail on the next slide. Census tract information such as distribution of age and race ethnicity were also obtained from census.gov. The mammography facility locations were compiled from the U.S. Food and Drug Administration, their certified facility list, as well as the American College of Radiology's accredited facility list. So we collected information on the location of these facilities in all sites in Delaware, as well as the border adjacent zip codes in Maryland and Pennsylvania, recognizing that Delaware residents who live close to the border may cross state lines for their mammography services. We also compiled the number of active mammography units per site from Delaware Health and Social Services. And this information we use to determine the capacity of each facility. So we first conducted the service area analysis. So to do this, we first mapped all of the existing mammography facilities. So these are the orange dots on the map. And again, we included all facilities in Delaware and then the adjacent facilities in Pennsylvania and in Maryland. And then second, we specified the parameters of the service area, which we decided to use driving time, meaning that we are using driving time as an indicator for geographic access. We also specified the cutoffs we wanted for the service areas, which we decided on up to 15 minutes driving time, which we considered to be very accessible, between 15 and 30 minutes driving time, which was moderately accessible, and then over 30 minutes driving time was considered the least accessible areas. Then the next step was to run the model and then export the map along with the data for each census tract. So this is what the map output looks like for the service area analysis. So again, we see the facilities as the orange dots on the map and the 3 service area cutoffs. So the most accessible areas are in the light teal. The moderately accessible areas are in the darker teal. And then the most accessible or the least accessible areas are not shaded, so everything outside of the teal. And so as you can see from the map, the majority of the existing facilities are in Newcastle County area, which is this space here that's surrounded by this gray box. And this is not surprising, considering that much of Delaware's population does live in this county. And as such, almost all of this county's census tracts were within 15 minutes driving time of a mammography facility. But in Kent and Sussex counties, only about 78% of census tracts were within 15 minutes driving. And so just by looking at this kind of crude analysis, it seems to be telling us that there may be adequate mammography facilities in Delaware, and particularly within Newcastle County. But we did do a concurrent regression analysis where we found evidence suggestive of disparities related to race and rurality. So for example, we found fewer mammography facilities and units in predominantly Black census tracts compared to predominantly white census tracts. So this suggests a need for additional mammography facilities in areas where women are eligible for screening, and particularly Black women. So this brings us to part 2 of our analysis, which is the location allocation analysis. The 3 steps that we took to conduct the location allocation analysis include the specification of demand, determining the quantity and locations of the demand points, and the allocation of the proposed facilities. So as I mentioned earlier, demand is the number of people that are in need of the services provided by the facilities. So in our case, this refers to the women eligible to receive mammography screenings according to screening guidelines. We decided to use 3 separate specifications and compare them based on different screening guidelines. The first screening guideline that we used was the U.S. Preventive Services Task Force recommendation, which is for biennial mammography screenings for all women between the ages of 50 and 74. The second specification is based on a simulation study conducted by Chapman and colleagues in 2021. Their work demonstrated that initiating biennial screening for Black women beginning at age 40 would achieve the same benefits of biennial screening at age 50 observed for white women. And this, in turn, could reduce the Black-white difference in breast cancer mortality. So for the second specification, we used this race-based guideline in addition to the USPSTF guideline. And then the third specification was based on the American College of Radiology's recommendation for annual mammography for all women starting at age 40. The second step of this location allocation analysis was to determine the quantity and locations of demand points. So using those 3 specifications that I just described, we calculated the number of women in each census tract that would be eligible for mammography screening each year based on census data for each census tract. And since we only had census tract level data, we calculated population-weighted centroids for each census tract, which is essentially the most heavily weighted population area within each census tract. And then we used this location to represent the locations of the women living in that census tract. And so this map shows all of the demand points, which are the gray dots, and this represents all of the census tract centroids for the first demand specification, the USPSTF specification. And so within the ArcGIS program, I can click on each of these demand points to see the characteristic of that demand point. So for example, when I click on this one, it tells me which census tract it is, which is 164.04, and it's located in Newcastle County. And then it also tells me how many women would be eligible for mammography screening in 1 year based on this demand specification. So for the demand specification, the first demand specification, the USPS-TF, we would have a weight of 265 women. So that would be the number of women that are eligible for mammography screenings each year living in that census tract. And if I did the same thing for the second demand specification, we would have 290 eligible women in that census tract. And then the last step of this location allocation analysis is to allocate the proposed facilities and run the location allocation model. So we specified that the proposed facilities could fall anywhere within Delaware, and we use the ArcGIS fishnet tool to identify those locations. So the fishnet tool essentially just like throws out a fishnet over the whole area of the state of Delaware, which is what you used, and identifies locations that are equidistant from each other. We calculated the capacity of each existing and proposed facility to determine how many women would be able to use their services each year. And we did this based on a calculation by Young and colleagues, which estimated that a facility with one mammography unit could perform an average of 4,500 screenings per unit per year. So we calculated that based on the existing facilities, and then for the proposed facilities, we just assumed that they would have one mammography unit, which was the state median. We used driving time to determine appropriate location allocation, and a 20-minute driving time was specified as the maximum amount of time an individual would likely travel to a site. The ArcGIS location allocation tool allows for several different problem types, and for this model we selected to maximize the capacitated coverage, which means that facilities are located such that all or the greatest amount of demand can be served without exceeding the capacity of any of the facilities. And then we ran these analyses 3 times for each specification of demand, each allowing for 1, 3, or 5 additional facilities to be added. So these 2 maps show the results of the location allocation analyses for the USPS-TF recommendation on the left and the race-based recommendation on the right. And both of these have been zoomed into Newcastle County just so you could kind of see the allocations a little bit better. And so you can see how the model allocated the demand, and again, those are the gray dots to each of the existing facilities. So the existing facilities will be either these green dots for the USPS-TF recommendation or the purple dots for the race-based recommendation. The model also decided on the most convenient locations for the additional facilities, which, again, for the USPSTF recommendation, that's the dots with the pink stars. And for the race-based recommendation, those are the dots with the yellow stars. And for clarity, we decided to output the maps without the lines between demand and facilities. So to describe the results, I'll show you those maps. Okay, so we can look a little bit closer at each of the two specifications of demand. So this map shows the results from the location allocation analysis using the USPSTF recommendation of biennial screenings for all women aged 50 to 74. So on this map, the green dots again represent the existing facilities, and then the purple dots represent the locations of the 1, 3, and 5 additional mammography sites. So this demand specification highlighted the opportunity to increase access in the more rural southern part of the state, and specifically if adding one additional mammography site to the 36 existing sites, the best location based on demand would be in the southeast region of the state near the town of Millsboro. If adding 3 new sites, which would include the Millsboro location, one additional site would be placed in the southwestern region of the state near the town of Laurel, as well as in the northern region of the state near the town of Newcastle. And then finally, when adding 5 new sites, which would include the 3 that I just described, the next additional site would be placed again in the southeastern region of the state near the town of Selbyville, and then one in the center of the state near the town of Felton. And then changing the demand specification to the race-based recommendations actually shifted the locations of the proposed mammography sites. So instead of the 3 proposed sites in the southern region of the state, 1 central and 1 in the northern region of the state, this analysis proposed 2 in the south near the towns of Laurel and Millsboro, 1 central near the town of Felton, and 2 in the north near the city of Newcastle and the Bear area. And this is likely due to the racial composition of residents of Newcastle County and the Wilmington area. Specifically, there's a greater proportion of Black women between the ages of 40 and 50. So those women that are captured by this race-based recommendation that live in this area, this northern region of the state, compared to the central and southern regions of the state. So as you've seen in this demonstration, catchment and service area analysis is a useful tool when you want to visualize and evaluate on a crude level access to healthcare services. And using this tool, we saw that on the surface, there appears to be adequate mammography facilities in Delaware. However, when we took into consideration the population demographics of the various regions of the state, specifically the northernmost county, we found disparities in access related to race and rurality. And so using the location allocation analysis, we were able to determine ideal locations for new facilities that would improve access to mammography screenings for communities that are in need of screenings but lacking. So these methods and our study in general do have a few limitations. The first is the use of drive time as a proxy for accessibility. So I did mention, that this assumes that women who are accessing these mammography facilities are driving themselves, meaning that we may not be capturing the time it may take to get to a facility on public transit or by walking or by any other mode of transportation. And while these analyses do have the potential to use walking distance, which I mentioned earlier, and there are also ways to incorporate bus networks into the location allocation analysis. We didn't include those in this particular study, but we do think that it would be an interesting extension. And additionally, this analysis did not take into consideration other barriers that may limit access, such as hours of operation, childcare, or insurance, as well as many more. So within these analyses, there are ways to introduce physical barriers as well as structural barriers, but in order to introduce those types of barriers, we would require additional data points that we just did not have access to using those publicly available data. And a second limitation is regarding capacity and the method that we use to calculate capacity of each of the facilities. So the assumption that we made was that each mammography unit would be able to perform 3 mammograms per business hour. But this calculation was developed prior to the COVID-19 pandemic, and it does not take into consideration the new cleaning procedures that could reduce the number of mammograms a unit can perform per hour and then per year. And then lastly, the actual feasibility of opening up and creating new facilities depends on a number of factors and more than just accessibility. But we do hope that this information could be useful for future planning. And I'd like to acknowledge my colleagues on this paper and in this project, Dr. Neil Goldstein, who's my faculty advisor at Drexel, and Dr. Scott Siegel and Dr. Jennifer Rowland from ChristianaCare. And I'd like to open it up for Q&A now.
Thank you, Jessica. Excellent talk. There's a quick comment in the chat. I'll just say, great point about public transport. Would be interesting to consider that for your future work. In addition to public transport, you mentioned that you could use this methodology for walking in addition to driving. Any thoughts on how easy or hard it would be to look at walking, whether or not walking is something feasible or something that individuals would partake in to get to a mammography?
Yeah, and we're actually thinking about that more for the Wilmington area where people may be walking more, using public transportation more than some of the more rural, central, and southern areas of the state. And really with this analysis and this tool, you can just change the specification and change it to walking time. So again, it'll be road networks, but it takes into consideration how long it would take to walk instead of drive.
And just a follow-up question, and do you have information on car ownership, or are you able to look at car ownership within the different census tract areas? And
So there is data. There should be data. We didn't use that for this particular analysis, but that's definitely something that we could take into consideration. How many people, own a car? How many people take public transportation within each of the census tracts? And obviously we'd see a higher proportion of people owning a car in the areas that are probably outside of the city of Wilmington or any of the other large cities in Delaware. So yeah, that's something that we could take into consideration too.
I'll ask one more question as people are thinking. Um, so thinking about interventions or kind of how you would guide interventions or suggestions you would make. One thing that I've sort of been aware of within our state is the like mammography vans or kind of bringing mobile mammography units. So how would you use the information that you just demonstrated in the work that you're doing to sort of guide or help programs that are, putting up these mammography vans or the mammography mobile units?
Yeah, so that actually makes, you know, access a little bit easier too, and feasibility easier too, because you don't actually have to, find a location or like build a building or find an empty building to host this mammography screening site. And the locations that we determine from the location allocation analysis could be used to determine where, a van could park. And since, vans are mobile, they could go to any of the various locations. And we could even, so in this analysis, we used 1, 3, or 5 additional sites, but we can do as many, additional sites as we choose for this like simulation. And the mobile vans would be a great way since they could move around. It would be a great way to see multiple locations or many different locations that the vans could service at a time.
Thanks, Jessica. Yeah, I see. Definitely. I mean, it seems like downstate is is kind of where you would focus a bit. Yeah, surprising, but maybe not surprising that there's such a need downstate.
Mm-hmm.
Great presentation. I really enjoyed it. A quick question about whether you have ever looked at on-site clinics, because I can assume many people who don't go to screenings is mainly because they don't have the time to do that. So I don't know if we have information about any clinics that are like on factories or any organization. I know that we have like a large health system here, but I was just curious if you have information about that.
So we didn't include that information in this particular analysis, but as I mentioned, this analysis is very flexible, so you could really add whatever information you want. And if you have location information for other clinics, you can add that, and you can specify that it's a different type of location, a different type of clinic, and change the the number of units or the capacity depending on what kind of clinic it is. Um, that's a separate analysis that we did actually as well, based on centers of excellence. And yeah, so you can basically stratify it and look at access depending on type of clinic.
Thank you.
Mm-hmm.
I think, Mina brings up a really good point. I love your thoughts. So, access or physical access is just one component of kind of the why of engaging in mammography. Um, I think your work sort of shows that in some areas, it may not be the physical access as to what the major barrier is. And there, maybe you'd want to explore a little bit different, but in other areas, if they don't even have the physical access, then, that's the place you need to sort of start.
Mhm.
Do you have any plans kind of to extend this work, or maybe your colleagues to extend this work to kind of then dive down into sort of smaller areas and really understand in those areas where physical access is, what are the additional barriers to screening?
That's a
Or
great, yeah, that's a great point. We hadn't thought, so we kind of just finished this project and this analysis, so we hadn't thought quite yet about like what next steps would be, other than, we've been talking a lot about looking at public transportation and seeing other ways, that people could access mammography facilities. But that's also a great idea, and I think, two people who worked on this project, yeah, are on this call, so we'll probably discuss some of these ideas later on for next steps. But yeah, that's a great
it'd be
idea.
cool to see, even if you had for the sites, like, are they open on weekends and nights, and kind of thinking about access also beyond just the physical. Yeah.
Mm-hmm. Yeah. Yeah, exactly. Because there's so many different characteristics of the different facilities. And with the flexibility of these models, you can really add as many kind of characteristics as you want and change how people who is able to access it, because that could differ as well.
Hi, Mia. This is Neil Goldstein. I'll just share a few more thoughts about this question because it's an important point in that what we're looking at here is more of a question of availability instead of accessibility. And we have a grant that's going in this month, in fact, that's looking at the second part of this equation, which is the accessibility part of it. It's not related to breast cancer screening. It's actually related to HIV screening in Delaware. But what we're going to do is kind of a same sort of approach. Look at empirically where are HIV screening sites located, see what the data tell us, and then we're going to go with a qualitative arm of this to interview service providers, patients, and other stakeholders to try to get at this. Just because something's available to you doesn't mean it's accessible, and there's good reasons, in fact, especially in the HIV world, why you may not want to go to the closest facility. So all this is part of some planned work that hopefully we'll be able to tackle in the next couple of years. But it's on our mind, and it's an important point that you're raising.
That's awesome, Neil. Thanks. Yeah, you could also kind of think about if you had individuals who did access those places, where they live and how far they do come and who's sort of driving to what location, to understand how people move through their space. It'd be really cool. Pragyan, you have a question?
Yeah, great presentation, Jessica. A lot of my work here is spatial related as well. I haven't used network analysts, so that might be a tool to look into for for us getting here at iReach. I kind of in that availability versus accessibility realm. I was wondering if there are ways to kind of look at in the existing facilities, like if any are like being underutilized per se. Because one thing that stood out to me was there were two facilities are very close to my home census tract that were very close together. And I was a little surprised by that. And it'd be really interesting to see like if any of those facilities were being underutilized, and in those specific target areas, what are the barriers to getting people to come in for screenings.
Yeah, that's a good point. And that's kind of something that we were initially a bit surprised about too, seeing so much concentration in like the Wilmington area. And we even considered, when we were looking into capacity of each of the facilities, we just found like a statistics about how many units each of the facilities had, but we did consider calling up each facility and say, So what do you think your capacity is? How many mammograms can you deliver an hour, like per year? So that would be a great, I think, extension to just like get a little bit more real, maybe information directly from the sites. And this is kind of something, that Neil was talking about, the more qualitative side of it, as opposed to just generally like how many does it say? How many do they say that they have and that they could use? But in reality, like who is going there? How often are people going, and is it being utilized? So yeah, those are very great points to bring up. And also, if you do want to get into the service area analytics or the network analytics, we did a previous analysis using this in Philadelphia, but looking for HIV testing locations, and published a paper that also has the full kind of like recipe book of how this analysis, so a little bit more detail than like what was presented here today.
Okay, yeah, I'll definitely take a look. Thanks.
Yeah.
I think, Jessica, you also made a great point about kind of this was pre-COVID and how COVID, has changed things with respect to not just kind of like the staffing and the facility, but also with respect to kind of changes in demand. And I don't know, but just kind of anecdotally that sort of I hear demand kind of decreased during COVID. People didn't want to engage. And so now like you have individuals where you might not be in that steady state, but you might have an increased demand. People are just catching up.
Mm-hmm.
Interesting how all of these metrics change and the impact COVID can have on everything we're doing.
Exactly. Yeah. And so changing the, I guess, capacity could change the locations. And that's something like we did a few sensitivity analyses changing, the maximum driving time we thought people would drive. So, we specified 20 minutes, but some people might not want to drive that long. Some people are willing to drive further. And it also really depends on where they live in the state too. So there's so many different parameters that you could specify and change. And so that's another one, the capacity, because the tool will only allow, the maximum capacity of individuals that can go to the facility to get the services. So that's something that could change the locations of the proposed facilities too.
That's awesome. And driving is really interesting. Like, is it driving from your home or driving from your workplace or driving from, where you drop off your child at school if you have, so like what is the convenient sort of piece, which is also really fascinating.
Yeah, exactly.
I was just going to add one comment. I think our priority for next steps is, up until now, we're sort of basing demand off of current patterns of use, or our assumptions at least. In the U.S., we do screening differently than a lot of other countries in that it's been described as more opportunistic. Either a person would self-refer or maybe a primary care would refer a patient for screening. In other countries, they use organized programs where they define a catchment area and then identify, in this case, women who are screening eligible, and then make a point of, tracking who's completed screening, doing outreach to those who haven't. We're not anywhere near as organized here. But in terms of addressing, at ChristianaCare at least, in terms of addressing disparities in breast cancer, this is something we're contemplating, where we want to be more proactive in terms of identifying women who should be initiating screening, doing this in a risk stratified way, so not all women may receive the same recommendation. Understanding what the implications of that are for changes in demand, and then matching that up to what we currently have in terms of our estimates of capacity. And as Jessica showed, really, the different demand specifications or the different guidelines that you use can change that pretty significantly, and it can change what recommendations you would make. So we believe, based on our preliminary work, that the areas that are highest risk are the ones where we anticipate seeing an increase in demand if we take a more organized approach. And those are the same areas where maybe we have less availability of mammography facilities. So I think that's maybe a direction we're headed, and we're probably more, at the moment, at least Newcastle County focused than downstate, just because, this is our catchment area.
Thanks, Scott. I will lead with one other thing, since I am a member of our disability advisory subcommittee here at Christiana Care, that I think women with disability and sort of how they access mammographies also more than just having a mammography place that's convenient, but also one that's actually accessible for individuals with disabilities. And so thinking about that and the population of women who are now 40, 50 years age and living with a disability has increased over time, which is a great thing. But now, how you think about access for special populations.
Yeah, that's a great point.
And Mia, that's the exact reason, we want to do the qualitative work here, is to get at these points that otherwise we just may be missing.
Yeah, I cannot wait to hear the results of that, Neil. Good luck with the grant application. Hopefully it's successful.
Thank you.
Because I agree, it's such a beautiful blend of the quantitative and qualitative to really kind of address the nuances of these issues.
Just a quick point, yeah, I think that qualitative part is so important because conditions are different, and something like HIV is very different from breast cancer. Like there are certain stigmas that are related to some conditions, and people may not want to go to the closest location, as what was mentioned before. So I think that's really important to consider.
True.
Okay.
All right, we are just about the hour. Join me in thanking Jessica again for a wonderful presentation, great discussion. Good luck with the rest of your dissertation. Excited to hear about your work with CTIF and continued work with this project.
Thank you so much for having me.
Thank you, Jessica.